Good afternoon, everyone. Thank you for joining us for our monthly HAI program regional call for the Northern California region. We hope you're having a good day so far. Today, we are going to be presenting two topics to you. Before we get to those topics, next slide, please. Just want to give you one announcement, and that is if you have not joined the KHAN to get your notifications from the California Department of Public Health, please go ahead and follow the instructions, send an email to the email listed on the slide here, and Zenit will put that email address in the chat as well so that you can have access to it sooner rather than later. And as we go through the respiratory season, you would be able to get your information on events that are occurring that we send out to all facilities. And today I am happy to introduce to you Vikram. Vikram is one of our team members. He is an epidemiologist with our program, specifically managing data validation. Next slide, please. And Vikram is going to speak to you about the 2023 external validation results that some of you participated in. Vikram?
Thank you so much, Adame. Good afternoon, everyone. Like Adame mentioned, my name is Vikram Haridas, the data validation epidemiologist with our program, and I work alongside our IP team during our data validation activities. So next slide, please. So thank you for your attendance today. I would like to share some summary results from the overall 2023 external validation. Specifically, we'll start with a review of the 2023 external validation timeline and facility participation outcomes, followed by the results recap of the 2023 external validation activity, and finish it off with details regarding the upcoming 2024 external HAI data validation. Next slide, please. In terms of the timeline and overall participation, there were 65 general acute care hospital facilities randomly selected for participation for the second round of on-site external validation visits with the HAI program IP team. The HAI types that were validated included CLABSI, MRSA BSI, VRE BSI, CDI, SSI COLO, SSI HIST, and SSI CSEC. External validation visits commenced on September 2023 with the completion of all visits by January 2024. Next slide, please. In terms of the distribution of the HAI data validation outcomes and similarities among facility participants, 38% of participants or 25 facilities identified at least one or more missed HAI events and one or more misreported surgical denominator data elements. 9% of participants identified at least one or more missed HAI events only. 42% of facilities or participants identified one or more misreported surgical denominator data elements only. And 11% of facility participants had no missed HAI events or misreported denominator data elements across all validated HAI types. Next slide, please. In terms of the acute care hospital participation for 2023 external validation, Table 1 shows the distribution of participants according to facility type. And we see that 8% of participants were community hospitals with less than 125 beds, followed by 14% of participants being community hospitals with bed sizes ranging from 125 to 250 beds. 26% of participants being community hospitals with greater than 250 beds, and 49% of participants being major teaching hospitals, and 3% of participants being critical access hospitals. Next slide, please. In terms of this being a fruitful exercise for the participating facilities, Table 2 shows the distribution of missed events across the validated HAI types among participating facilities. We see that 52% of participants identified no missed events among all validated HAI types, followed by 20% of participants who identified at least one missed event for only one of their validated HAI types. Followed by 15% of participants who identified at least one missed event for two of the validated HAI types, 8% of participants who identified at least one missed event for three of the validated HAI types, and then there were 5% of participants who identified at least one missed event for four of the validated HAI types, and there were no facilities that identified at least one missed event among five or more HAI types. Next slide, please. Table 3 shows the facility level average and median case finding percentage levels. Generally, all facility participants reported events into NHSN with high accuracy across all HAI types, as can be seen by the average case finding percentage levels at approximately 90% or above. Notably, the SSI colo and SSI HIS case finding percentage levels were found to be below the average case finding at approximately 90%, with SSI colo being 88% and SSI HIS case finding percentage being 87%. Next slide, please. Table 4 shows the facility level average and median surgical denominator data element agreement percentage levels. And we see that reporting of surgical denominator data element into NHSN was highly accurate among our facility participants, with the majority of the denominator data element percentage agreements averages being at or above 90%. For colon surgery, we did see that BMI was observed to have the lowest average denominator data agreement percentage at 79%. For abdominal hysterectomy procedures, surgical duration was observed to have the lowest average denominator data agreement percentage at 85%. This was similarly observed for cesarean section procedures and the supplemental denominator data element validation component, with the average denominator data agreement percentages being 88% and 91% respectively. And interestingly, in 2022, surgical duration was also found to be the common denominator data element that was reported with lower accuracy into NHSN. Next slide, please. Table 5 shows the overall validation proportion distribution. This table shows the distribution of facilities according to the percent of HAI types that were validated in which the case finding percentage was greater than 85%. Greater than or equal to 85%. For example, if your facility's overall validation proportion was equal to 50%, that interprets as half of the validated HAI types were identified with a case finding percentage of 85% or more. So 2 of 4 validated HAI types or 3 of 6. And therefore, that interpretation is applied to the percentages shown in column 1 of the table. And across all facility participants, there were three general groupings related to this proportion of validated HAI types identified with a case finding percentage of 85% or higher. 14% of facilities had an overall validation proportion of less than or equal to 70%, followed by 21% of participating facilities with an overall validation ranging from greater to 70% to 87.5%. And 65% of facilities with an overall validation proportion ranging from 90 to 100%. In that case, if you validated 4 HAI types, 100% would be all 4 validated HAI types had a case finding percentage of 85% or greater. In terms of, next slide, please. In terms of the accuracy of lab ID event reporting, according to infection onset status, table 6 shows the facility level average and median case finding percentage levels for lab ID events according to NHSN defined infection onset status. Generally, all facility participants reported events into NHSN with high accuracy across all HAI types, as can be seen by the average case finding percentage levels at approximately 95% or above. Interestingly, the accuracy of reporting lab ID events meeting the NHSN criteria for hospital onset events was consistently higher than the average case finding percentages for community onset events for a given lab ID event type. Notably, among MRSA BSI and VRE BSI, event reporting was at an approximate 5% lower average for both. Next slide, please. In terms of the upcoming 2024 external HAI data validation, that is starting this week, the week after internal validation has just been completed. So our team will have additional info and we'll be in touch. Thank you so much.
Thank you, Vikram. So to continue where Vikram left off regarding the external validation, our team has started contacting facilities that will be participating in the 2024 external validation exercise. And it is really those facilities that did not participate in external validation in 2022 and 2023. So please note, if you haven't participated in any external validation in the past 2 years, we will be reaching out to you to extend an invitation to participate in this year's external data validation. Some persons asked in the previous meeting with the SoCal team, what is external data validation? And basically, it is an HAI IP member, 1 or 2, come to your facility on a date agreed to by you and the IP to take a look at and evaluate your data. And if you participated in internal validation that just ended on Friday, the elements that will be validated for external are slightly different. So we will be doing the lab ID events, all 3, MRSA, VRE, and CDI. We will be doing 3 surgical procedures instead of the 2 that you did in internal validation, and those 3 are C-section, hysterectomies, and colon procedures. And we will be looking at CLABSIs. And finally, you only did 1 quarter's worth of data validation, and we will be looking at 2 quarters, so January through June. When they contact you, they will give you the instructions for how to pull the data necessary for that validation. So we encourage you to participate, as it gives us a lot of feedback as to what are some of the things that we can help you with strengthening your surveillance and reporting capacity. Next slide. So as we go into the respiratory season, we don't say flu season anymore, because there's so many respiratory viruses floating around at this time. We wanted to make sure that you are prepared, that you have the necessary guidance in place, the necessary strategies, and are aware of them, and can implement them so that you can prevent transmission in your facility. So we're going to get started off with the AFL 23-30. And that looks at how to prepare for adult and pediatric surges. These guidance are looking at hospital planning and your response to these illnesses as they occur. And also, this AFL contains some links to resources that includes clinical recommendations, vaccination, and it's looking at both COVID, flu, and RSV, and making sure that you know what early treatment interventions are available to reduce severity and illness. And then there are some temporary waivers that you can implement or request to implement regarding space. So if if you have surges happening in your facility and you want to flex a space in your building, you can click on this AFL, Zenit will add that link in the chat for you, and you can see how to apply for that temporary waiver. Next slide, please. Now, this is the recommendation for the 2023-24 prevention and control of COVID, influenza, and other respiratory viral infections. As the last group asks, there is no 2024-25 guidance. This came out in 2023, 2024, and so this is still applicable. And so the key messages are, one, of course, making sure both care workers and residents or patients are up to date with their recommended vaccines, making sure that you have a policy in place for source control, and also initiating those prompt testing and treatment of those various viral infections. Next slide, please. Of course, once you have the appropriate policy, procedures, and guidance in place, you want to start monitoring. You want to monitor for signs and symptoms. And if your patients and residents are displaying these common signs and symptoms of respiratory illness, you want to consider starting a line list so that you can keep track of where this is occurring. Maybe you're just seeing it come into your emergency department, or maybe you are seeing it in a particular setting within your facility. So keeping that line list will help inform your additional practices and guidance. And of course, you want to make sure that your healthcare providers or your healthcare personnel are being screened. They themselves should be screening to see if they have signs and symptoms before reporting to work. And you may want to institute some type of active screening for them. They may need to attest to the fact that they had a positive COVID test, or they're having symptoms or fever, or they've had close contact with someone who was positive for COVID-19. Next slide. As of April 3rd last year, the state of California no longer required masking in indoor healthcare settings. And so your local public health can mandate masking in your jurisdiction. So please pay attention to that, especially if they are seeing surge in community numbers. Also, there may be counties that you belong to already that have masking guidance for influenza. And so you will already begin to start your source control masking for that. And then if you click on the link that we have for guidance for face covering, you will see that it says these guidance are no longer in effect because those were rescinded. But in that guidance, it does tell you that we are now tied to the CDC COVID-19 community levels. And if you're interested, you can, when you open up this AFL, you can still access it. There is a link in there to the CDC's community levels that you can take a look at. Next slide, please. And these are some of the community levels that I just spoke to about CDC, the low, medium, and high, individuals in the community, what is suggested for them in terms of masking, and then the same for your inside of your facilities for your staff, your patients, and or residents. And then, of course, if your local public health has other considerations, you want to make sure you're following those. Next slide, please. So your patients have symptoms or confirmed for COVID, influenza, RSV, or any other respiratory virus. And so you want to make sure that you are implementing appropriate transmission-based precautions. So are you wearing the right mask or respirator when it's necessary? The eye protection, is gown necessary, gloves, and then the duration of the illness. And as you can see, COVID-19 duration of illness is still 10 days. And there are some nuances regarding that 10 days and return to work policy. Next slide, please. So your healthcare worker is symptomatic for COVID or have COVID-19 exposure. And so if they are symptomatic and at work and are not wearing a mask, that's the first thing they should do is put on a mask, notify their supervisor, and then they should leave and be tested for both COVID-19 and influenza. If they test positive for COVID-19, we do have return to work guidance still outlined in the AFL 21-08.9. That's still in effect. And if they are returning to work before that 10 days, they will need to practice source control with a fit-tested N95. Please make sure that your healthcare worker is aware of your stay-at-home policy when sick. You may need to dust that off and make sure that they are in compliance. And please remember that if your healthcare worker has had close contact with someone with COVID-19, they are not restricted from work, but should follow the testing and masking guidance that is also outlined in the AFL 21-08.9, and Zenit should be putting that in the chat for you so you can access that. Next slide, please. Thank you. So this is just a schematic of managing those healthcare workers who are infected with SARS-CoV-2 or COVID-19. So the work restrictions for them, you can take a look at this at your leisure. And it has to do with critical staffing shortage. During the previous call, SoCal call, someone asks about what is considered critical staffing shortage, and I mentioned to them that they can review the guidance located in the CDC. And CDC basically does not spell out what is staffing shortage, but it has some capacity strategies, three particular that they take a look at. They look at contingency, capacity strategies, and two others, crisis capacity strategies to mitigate staffing shortage. And it's clearly outlined and explained. And so you want to pay attention to that so to help you understand your response regarding your staffing shortage. Next slide, please. And also, as of April 3rd of last year, the state of California no longer require vaccination and boosters for healthcare personnel. That was outlined in the state public health officer order. And so if you did take a look at this link, you will see that. However, like the masking guidance that are no longer in effect from the California state, your local public health department can institute vaccination requirements, as well as your own facility leadership can require COVID-19 vaccination. Although vaccine requirements for healthcare personnel from the state perspective is no longer in effect, state still does strongly recommend that healthcare workers remain up to date, not just with COVID-19, but for influenza and any other recommended vaccines. Next slide, please. So I just want to tee up for some questions. Next slide. So not a question per se, but just giving you some resources on if you did ask yourself, well, how can I improve my ventilation in my facility? And so we have some links here that Zainat will put in the chat for you so that you can take a look at what are some of the strategies that can be implemented to improve your ventilation of isolation areas. Next slide. The question is about the nursing home. Do they need to transfer residents with COVID-19 if they do not have a true airborne infection isolation room? Next slide. And the short answer is no. The decision of whether to transfer a patient or isolate the patient on site is a discussion with that facility and the local health officer or public health department. As you see on this slide here, Cal OSHA still considers SARS-CoV-2 a novel pathogen. And so they do have requirements for skilled nursing facility to place residents in a AIIR unless doing so is not feasible. And next slide, please. This has been a question that has been circulating around TB testing requirements. And we just wanted to remind you that Title 8, Section 5199 states that it's legal requirements in California that they prevail over any recommendations that comes from the CDC. And so if you've seen some new updates from the CDC regarding TB testing frequency, you want to make sure that you are still in compliance with the California Code of Regulations, Title 8, Section 5199. We had a healthy discussion in the SoCal call regarding the AFL that came out in 2019 for a waiver for TB testing. And that waiver basically was looking at the shortage of the tuberculin skin test availability and had some guidance as to program flexibility. As far as we know, that AFL has not been rescinded. So I guess if folks are still looking for a waiver, they would have to follow the guidance in that AFL. But as far as we know, there is no general waiver for facilities to reduce the frequency of their tuberculin skin tests as defined by Title 8. And we'll open it up to questions from you, the audience.
We had some in the chat. Let me see if they've all been.
While you're getting your chat together, Joanna Mills has her hand up. Joanna, you can come off mute.
As always. So is there any indication that Cal OSHA will consider the science and the CDC related to COVID-19 not being a novel virus anymore, given the strict definition of what a novel virus is.
How would you like for me to answer that? So, not working directly with Cal OSHA, I have no idea what they're thinking, but we can certainly pass that on to them and say, will you be reevaluating the status of novelty for this virus, or do you have other plans?
And the other thing is related to that and the recommendation for airborne isolation for COVID-19 in the acute care environment. Even the most current CDC document for isolation does not explicitly identify COVID as a novel virus anymore, and also the type of isolation that's required. So, like I said, doesn't the CDC's determination supersede Cal OSHA, or is it always the most stringent of the recommendations that get complied with based on the state standard?
I love Joanna's question because she knows the answer already. Just asking it for you novice IPs. Yes, you always go with the stringent. As you know, that CDC is federal and Cal OSHA is state. And so state is asking for more stringent guidance. And so we will follow the state until they come on board with CDC's requirements or recommendations. Remember, CDCs are always recommendations, not requirements.
Thank you.
All right, Zenit, you have questions lined up?
I have some answers. So somebody had asked 65%, 65 represents what percent of local California hospitals, not 65%, sorry, 65 hospitals represents what percentage of total California hospitals, and that's from the sample size presentation. And Vikram answered that one, that it is approximately 16% of California hospitals. There's another question about discrepancy between duration of procedure. Could it be due to manual calculation, or is there a problem in the EMR calculation? It's commonly observed that, at least what we've seen in the past 2 rounds, that there is this discrepancy. So we're going to see in this 3rd round if there is less discrepancy. And we use 10 minutes, so there shouldn't be that much discrepancy in the calculation. Oftentimes what we see is instead of using cut time, they might use the time that the patient is in the room, or one of the other times of the many that are documented. So making sure that we are calculating it exactly from cut time to close time, and hopefully that will eliminate some of the discrepancies. There's a question about flag codes, and that we will provide the IP team when we go out. We'll give you direction on those. Our acute care, oops, keeps changing. Sorry, it jumped. Are acute care hospitals still screening patients in the ED for COVID symptoms? What does CDPH recommend for the screening practice?
We don't have clear guidance for screening anymore like we did during the public health emergency order. time frame. And so it may be based on what's going on in your community, and your local public health may reach out to you as well to acknowledge the need to do screening and testing for patients. But I know some hospitals are taking it upon themselves to do so, especially if they're seeing patients coming in with respiratory symptoms. And Zena, if you want to hold for a minute, I see Elaine has her hand up. Elaine, can you ask your question or say your comment?
Hi, mine was just a comment about the duration discrepancy seen in the reporting. External validation, we were one of the organizations that struggled with duration discrepancy. We use Epic. We took the Bugsy program out of the box and discovered that there was no way to get the cut time. They had not built that into their initial report building processes for data abstraction for procedures. You could get the incision time, but you couldn't get the closure time correct. So we've been working with Epic on that for a couple of years, and this year we did not seem to experience a problem with duration, but we didn't have the external validation done. And if anybody else is using Epic, Bugsy, they are in the process of optimizing their procedure duration processes as well as their coding processes. So that may hopefully help everyone who has Epic if you're struggling with duration discrepancy. They're also doing the same thing for wound class and SSI detection. They're trying to refine all of those tools.
Thanks for that heads up, Elaine.
Mm-hmm.
All right, Zena, continue.
If you do take a look in the chat box, thank you, Rita. Rita commented that one of the links, I'm sorry, jumped again. Where'd it go? The guidance for face coverings is an archived guidance, so we will make sure that that gets corrected in the slide deck. And so
No, Zena, it was meant to be, because that slide is showing them that that guidance is no longer in effect. And
okay,
so
we meant to
when
say that it was no longer, okay.
Yeah, so when they click on it, they will see, it's just proof that this guidance is no longer in effect.
Okay, and Rita was kind enough to then in the chat post the current guidance. So it's in the chat if you would like to access that. Thank you, Rita. Thank you, Item A, for the clarification. What if local public health determines that exposure testing is no longer required for exposed healthcare providers?
I think that would be a good thing for you, maybe.
Yeah, if it's no longer required, then you're no longer required to do it. Again, like Item A said, every facility can choose to have more stringent guidance if there's a need for it. Will there be a standard COVID-19 testing recommendation prior to transferring patients from acute care to SNF to behavioral health, etc.?
Not that we are aware of. There is no testing requirement at this time. You can transfer your patient over. Skilled nursing facility may try to ask you for one, but there is no recommendation from CDPH that must be done.
Here's a comment. Novel has PPE recommendations for including eye protection in addition to use of respirator for both, both necessary to prevent transmission of SARS-CoV-2.
I think that's a statement and not a
Yeah,
question.
it's a comment there. Thank you. maybe something coming down the road. Someone shared that their HR went to a conference and they were told that fit testing doesn't need to be done annually and or more frequently if staff lose weight, etc. Is there a waiver or are there conditions in which an acute care hospital could not do annual fit testing, but move it out to every 2 or every 3 years?
Fit testing is a Cal OSHA, it's part of the Cal OSHA requirement. So until they make changes, you'll have to comply with the annual fit testing.
Yeah, I'm wondering if Cal OSHA was at that conference or if it was a Cal OSHA conference. Another question is, will CDPH require any additional respiratory virus data to be reported to NHSN in addition to what CMS is requiring?
Not that we have been advised of at this time.
Just giving it a once over to look for some more questions.
As you look for questions, Zenith, just want to remind folks that you will receive a copy of our slide deck today. Our recording is taking a lot longer than usual to be ready for distribution. So we can send the slide deck ahead of the recording and share the recording with you when it becomes available.
I don't see any other questions. Oh, one just came in. For healthcare providers, both COVID-19 and flu are not required or only COVID-19. Thank you for the clarification.
So in terms of the state requiring vaccine for COVID, that is no longer in effect. However, we still strongly suggest that you stay up to date with all your vaccines. There may be certain counties that require vaccination, as well as your employer can require certain vaccines. Next slide, please. So we've come to the end of our discussion and presentation with you today, and we thank you so much for participating. Our next regional call will be held on Monday, October 21st, same time, 1 p.m. And we encourage you to think about other topics that you would like for us to present, or if you have a speaker that you felt was provided great information that can be shared with all, let us know. But October's presentation will be by our AR team, and they'll be providing you some updates on AR prevention and response. And we look forward to having that discussion with you next month. If there are no further questions, enjoy the rest of your afternoon and take care.